All right. Hello, everyone. This is Dr. Pruett. Today we're going to be talking about something that I think makes most people, including me, a little uncomfortable. So by talking about this, hopefully we'll make it a little bit easier of a topic for when this happens. We're going to be talking about death notification. And it's a pretty uncomfortable topic. Nobody really likes to talk about it. It can be a little bit awkward. But this is probably one of the most important things that we do on our cardiac arrest scenes for families. They're going to remember this day for the rest of their life, and we need to be able to do a good job at it. So some of the common problems with death notification would be maybe a fear that the family is going to blame you, that this is your fault, that you couldn't save them. Maybe we just don't know what to say. I know I get speechless a lot of the times. And then if we do say it and we aren't afraid of being blamed, how are we going to cope with however they're going to react? Because sometimes these reactions are incredibly unpredictable. And then ultimately, what do you do with your own emotions in this situation, realizing that you're trying to address the emotions of someone else? So cardiac arrest, we see it a lot, and we know that it's not like the movies. You don't just stab a needle in the heart and then they wake up and start talking. That doesn't happen. And most of the time, the reality is that we're going to be leaving this person on scene in the custody of police or the medical investigator. And so we need to be prepared to have that discussion with the bystanders and with the family exactly what's going on and what to expect. We know that even sometimes when we get the pulse back and we get a ROSC, they're not always going to walk out of the hospital with a neurologically intact survival. That's the very, very few, small minority that actually happens to. And so we need to be able to communicate that effectively and set those expectations clearly when we're on scene. So we do know, based on the literature, that there's certain things that help predict survival from cardiac arrest. One of those is if the person has a witnessed arrest. So if they collapse in front of a bystander who hopefully knows CPR, that is the best possible situation. And then it gets even better if there's a defibrillator close by and the patient is in a shockable rhythm. That's the ideal situation for cardiac arrest. But even then, if all of that chain of survival lines up perfectly, sometimes people don't survive. We're doing our best to train the community to be more familiar with CPR, be more familiar with AED use. But until our community gets a little bit better at this, a lot of times we'll arrive on scene and none of this will be in place. And we know that doesn't portend well for our patients usually. Now that said, I always like to say that patients don't read the textbook. So you could still have the patient that had the unwitnessed arrest without a shockable rhythm that we get ROSC on. So I know you know this, but we just need to be prepared for any situation. But I feel like if you know the predictors of survival going in, you have a better idea in your head of who you're going to get ROSC on and who you're not. The most important thing to remember as you're talking to these families is just be yourself. Try to be as genuine as you can. Don't try to be like someone else in this situation. They're going to be able to see right through this. So whatever it takes for you to communicate the following things, do it the way that you would normally do it. Importantly, families probably aren't going to remember the words that you say exactly, but they're absolutely going to remember how you make them feel. And so try to be as genuine and as empathetic as you possibly can. If you have time on scene, once we kind of get set up and things get going, if you're in charge of the scene, especially for you officers out there, do your best to step away if you can. Obviously, take care of the patient first, but once we have plenty of hands on scene here, so if you have time, acknowledge that family member, make the introductions, talk to them early, and keep them updated throughout the process. That's going to go a really long way in letting them know who you are, explaining what's happening, and then ultimately, if you have to deliver bad news, that's a lot easier to do if you've already established that relationship and those expectations early. I always try to do my best to make them comfortable. They're in an incredibly emotional state usually, and if they're elderly and frail, I like to have them sitting down to where they're safe. And then it's always a nice thing if you can kneel or sit with them as well. Try to not be in a overarching position of power or intimidation. You want to convey the fact that you're not in a hurry and that you're caring and that you're empathetic, and make them feel comfortable. Realize that if you're working on a patient whose heart is not beating and they're not breathing, that person is technically dead, right? So your new patient is the one that you're talking to right in front of you. It's the family member. And so do your best to take care of them as well. So listen to them. Try to find them some support, whether it's helping them use their cell phone to call a son or a daughter or a friend to come and be with them in this time of grief, or offer other resources. Maybe if they're alone, try to find the police chaplain or someone else who can come to the scene to be with them while they're experiencing this loss. What you want to do as early as possible is kind of set the stage for exactly what's going on and not give them any false hope. Realize that these people do watch movies and they do see that 90% of people just wake up the minute they get shocked, and you need to explain in a kind way that that doesn't always happen, and let them know your kind of expectations and what's going to happen from here. It's kind of nice to maybe fire what we call a warning shot initially as the team is there. You're assessing the patient. You know that this is a confirmed cardiac arrest. It's nice, the way I usually say it with the family is, when we got here, his heart was not beating and he's not breathing on his own. And you kind of set the stage that at this point, our team is doing everything for him. We're breathing for him and we're circulating blood for his heart to see if we can get it to restart. So usually with those words, the lay public can understand the gravity of the situation. Another thing I try to do is just encourage the family member, help them avoid any feelings of guilt. It's fairly common for them to think, well, maybe I should have called 911 earlier, or I should have taken him to the doctor yesterday, or start to try to blame themselves right there where they're on scene and this is going on. I try to alleviate any of that as soon as I can by telling them that they did the right thing by calling EMS and that they gave him his best chance at survival. After that, if you have time, and this could be ongoing with periodic updates, but it's always nice to let them know exactly what's happening now and what they might be seeing in front of them. I usually try to emphasize that we're doing everything we possibly can, and what we're doing is the exact same treatments that this patient would be getting in the hospital, that we've essentially brought the hospital to them so that they don't have in the back of their mind a question of why you're not loading them into the ambulance. Try to emphasize that it's actually better care to do this right where we're at right now. I always try to emphasize that our team is very good and is giving excellent care. Next, you kind of want to explain what's going to happen next over usually about the next 30 minutes. I tell them that we do our best to restart the heart for about 30 minutes, and that if we can't get it to restart after 30 minutes, then that's usually when we stop, because we know based on science that it doesn't usually get any better after that. If you have an ultrasound on scene and you're planning on using it, you can explain what that tool is and what we're looking for with it and how it helps in our assessment of the situation. This might also be an important time to ask about advanced directives depending on the situation that you're in. I always like to ask the next of kin what the patient would have wanted in this situation. It's not what the next of kin would want, it's what the patient would have wanted. Sometimes they don't always have that written out, but if you have the next of kin there with you who is de facto the decision maker, it's important to emphasize the point that they're there to make the decision that the patient would make in this situation. Sometimes you'll see them produce a power of attorney for healthcare. Sometimes there's physician's orders for life-sustaining treatment. There might be a living will or even a DNR DNI. If there is a DNR DNI that's signed, go ahead and honor that. It's very important to honor the patient's wishes, but until you see that, continue BLS care until you can confirm that order. Frequently, this is about the time that you'll be calling for medical direction for either help determining the advanced directives or for termination of the cardiac arrest as this progresses closer to 20 or 30 minutes of resuscitation efforts. It's always easier on the other end of the phone if you just state your name, your title, and your agency right up front. And if you can kind of set the stage with exactly what's going on, realizing that physicians get calls for a lot of different types of things. So if you get their mind in the correct framework right up front by saying, I'm calling for termination, they can immediately start to dial in on what questions or what things they're listening for when you present the patient information. So just like any patient presentation, you want to start with the age and sex of the patient, and then the important questions. So was this witnessed arrest? What was the initial rhythm? What is their current rhythm? What was the initial entitle? And what interventions have you done to this point? Those are all going to be questions that are going around in their mind and are listening for you to report to them. So if you can report them all in an orderly fashion really early, it makes that decision and that discussion a lot shorter and a lot easier. After you have confirmed order for cessation of efforts or for termination of the cardiac arrest, it's time to convey that to the family. The easiest thing to do is just to say it. So again, sit down with them, have them in a comfortable place, anticipate that they might not take it well, but you want to say, the way I usually say it is, I have the worst possible news for you, and I'm very sorry, but despite our best efforts, we couldn't restart his heart, and he died. So do your best not to use euphemisms when you're talking to the family. You want to just come out and say it. Make sure you use the word dead or died. You want to be direct so they hear it, but also be as compassionate as possible. It's fine to sit there in silence with them or allow them time to react. I usually give them a minute and just sit there, and then it's okay to express sympathy however you want to do that. If it's, I'm sorry for your loss, or even give them a hug. Every situation is different and every person is different. So just read the situation and do what you feel is appropriate in that instance. Realize that reactions to unexpected death are very unpredictable, and this can go any one of a million different ways. So in the back of your mind, as you're sitting down with this new patient, be cognizant of your surroundings and have nobody between you and the escape route if you need to, if they become violent or angry. And it's always a good idea to have police there if you need to, just in case there's a violent reaction. Now, there is two different types of deaths that we have in our system. There's what's called attended death and an unattended death. Unattended death is our typical deaths that happen like in a house or in the street or in a restaurant, anywhere outside of a healthcare facility. And in these deaths, these are the ones where we call for police. Police will stay on scene until the medical investigator gets there, and then the process moves on from there. An attended death is a little bit different, and this usually happens in a healthcare facility where there's technically a medical director who is in charge of the medical staff. So like a nursing home or a SNF or a long-term care facility. If a death happens there, you're not always going to have police present. And so realize and anticipate that. If you're working a cardiac arrest there and you're anticipating a potentially violent reaction from a bystander, go ahead and call them to the scene. But it might not be the same process of events with the medical investigator, because that facility counts as an attended death, and the facility will take charge of the body from there. Every situation is different. I know that we do this a lot, but just follow your intuition. If you feel like the patient needs a hug, give them a hug. If you feel like they just need to sit there in silence, that's fine. Do whatever you think is appropriate in that instance to convey your empathy and your caring. Things I would encourage you not to do, just to make this go a little bit smoother, is do your best to not be in a hurry. Even if you kind of are deep inside, try to do your best to hide that. Take time to sit down, take time to listen, take time to just let it be silent for a minute if you need to. Do your best not to use medical jargon and to explain things as simply as you can. Just say it when a patient dies. Don't use euphemisms because there's a chance it might not be understood. Try not to judge people's reactions and be as compassionate and forgiving as you can, but also keep in the back of your mind that your own safety is paramount. So always be prepared to do what's best for you if you need to. I pretty much had practiced this when I was early in my training, and I have a speech, and it's pretty much the same speech I give every time. So if you are anticipating having to do this death notification for a family, my advice to you would be to have your set speech down so that when it comes time to give it, you're ready and you're not having to do it on the fly and it doesn't feel as uncomfortable. My speech goes something like this. Hello, Miss Jones. My name is Dr. Pruett. I'm the provider in charge of the care of your husband, David, today. As you know, when we arrived, he wasn't breathing and his heart wasn't beating. You did the right thing by calling EMS, and you gave him his absolute best chance at survival. I want you to know that my team did everything they could, and they did an excellent job. But despite our best efforts, unfortunately, he died. And if you have something along those lines, it makes it a little bit easier. There are some common operational issues that we need to consider. One of the questions that comes up frequently is, should the family be present for CPR? The answer is really, it just depends. Sometimes this is a very good option when it's appropriate. It helps the family with closure. It helps them to see exactly how hard you're working to resuscitate this individual. It might be a good thing to consider if you're there on scene and the family is present for CPR, to have someone there with them to explain exactly what's happening and to narrate everything that's going on and to answer questions as they arise. There's actually been studies of how effective it is to have families present for CPR. There's studies that show it provides a sense of closure, it limits the rates of PTSD at 3 months, and it doesn't tend to interfere with medical efforts at resuscitation. It shows the family that you're working very hard and you're doing your best to save their loved one. Now, there are exceptions to the rule, so if the family does become agitated and they need to be removed from the scene because they're interfering with efforts, then that's okay. But just realize that the majority of the time, this might actually help them with their healing and with their coping with the patient's death. Another thing that has been an issue in the past is, as you're working on this patient, this is your patient and you have total control over what happens to that body and what happens on the scene. But the minute you stop, the scene is owned by police. And so this is absolutely dependent on the situation. But if the circumstances permit, and this is the right kind of setting, and you coordinate with police ahead of time, I have actually had the family members come up and either hold the hand of the individual who's experiencing cardiac arrest or maybe kiss them goodbye, realizing that they couldn't interfere with any resuscitative efforts, but at the same time knowing that when you stop, they're not going to be able to touch that body or see that body at all, because then it's a crime scene and that body belongs to police. So while the body is still under your care and you think it would help with their closure, consider coordinating with everybody on scene. And if you think it's safe and police say it's okay, you can allow them to maybe hold the hand of the individual or kiss them goodbye before you stop. I think it's a very respectful thing to do before we stop or immediately after we stop resuscitative efforts, just out of respect for the individual, to have about 10 to 30 seconds of just silence to respect that person's life and to think about it for a minute. After we stop and we start to clean up and the code has been ceased, continue your relationship with that family member and maybe ask if they have any questions. It might help them if you explain what's going to happen next. So as people are starting to clean up, explain that, ask them not to touch anything or remove any tubes or things that have been placed. Let them know that police are in charge now if this is an unattended death, and then the police will stay there with them until the medical investigator arrives. Remember that it's not going to be so much what you say, it's going to be how you interact with them and the empathy that you're able to convey. And just do that the best way you possibly can. Don't try to be somebody else, just do it the way that you would normally do it. But they're going to remember how you make them feel. So do your best to realize that and treat them kindly. There's different stages of grieving. They might go through all of these really quickly, or you might find them in any one of them. So just be prepared. They might be bargaining, they might be in denial, they may be angry. depressed or just quickly accept it. You can't really tell, but anticipate any one of these emotions. And then realize that you might experience a lot of these emotions as well. We see a lot of very difficult things in the field. As they start to pile up, or if one of them hits you particularly hard, please don't hesitate to talk to somebody about how you're feeling. We need to take care of ourselves and take care of each other just as much and as good as we take care of our patients. So please don't hesitate to talk if you need to. And if you have any questions about this, please ask your 7-8 or reach out to me. I'll be happy to talk about it more.